Hello, my name is Dr. Roberto Vargas, and I'm Assistant Dean for Health Policy in the College of Medicine at Charles R. Drew University of Medicine and Science. I also direct our health policy pillar in our Urban Health Institute, a research center here at Charles Drew. Today, I'm going to talk to you about place at CDU, hopefully to set the stage for a series of lectures that you're going to hear as a part of this series. Place at CDU is consistent with our values in the sense that what we want to discuss during this series is the role of geography and place and where people live and the things that people are exposed to in different regions that affect their health, and especially how those things which might be modifiable about a place can help to improve the health and conditions of those who live there. Our CDU Vision and Mission is consistent with these overarching goals: excellent health and wellness for all in a world without health disparities. The university is a private, not-for-profit student-centered university committed to cultivating diverse health profession leaders that are dedicated to social justice and health equity for underserved populations through outstanding education, research, clinical service, and community engagement. The CDU Advantage inculcates this spirit in our mission and our values. It's a promise of specialized education that creates medical and health leaders who are able to conduct and translate empirical works in the quest for social justice and health equity globally, and who, in partnership with community, serve as agents, activists, and advocates for policy reform and catalysts for societal transformation, especially for underserved populations. This conduct and translate of empirical works and this partnership with community is part of what we hope to share with you in the setup that we've had for Place at CDU. What I'm going to share with you today in terms of what we've done in response to COVID-19 and how we've tried to help support our community, and how this has also led us to have a different view about the COVID-19 pandemic, and how that view has been translated to research that you're going to hear about later this week is part of what I'm going to share with you today. First, a little background on Charles R. Drew University. We were founded in 1966 as the Charles R. Drew Postgraduate Medical School here in South Los Angeles, this region in the center of this map, which was also the home of the Watts Rebellion in 1965. The McCone Commission looked at the conditions that led to this revolt and found that one of the things that contributed to the civil unrest was the poor health status and the diminished access to health care of individuals who lived in this community. And as such, supported and led to the founding of what is today Charles R. Drew University of Medicine and Science. Our history from 1966 to 1978 includes the founding of the Graduate Medical Education Program, the groundbreaking for what would become the Martin Luther King Hospital, and the establishment of a medical degree program in conjunction with UCLA in 1978. Our history also has had some challenges. In 2007, the county-run hospital that served as the main teaching hospital for a lot of our research and clinical education closed. That hospital, a publicly funded teaching hospital that was operated by the Los Angeles County Department of Health Services, closed, resulting in the loss of 450 hospital beds and 17 residency programs, the graduate medical education programs that were the foundation of the university today, which included losing 240 medical resident physicians. Those are doctors who finished medical school, were now trained under senior physicians to learn how to care for people. And that was happening here in South Los Angeles at the time of that closure. However, since that time, we've had a lot of progress. In 2015, the Martin Luther King Jr. Community Hospital opened up, a new hospital, albeit smaller, returned acute care services to that region. Graduate medical education was brought back to South Los Angeles for the first time since 2007 by our team here at CDU, starting with family medicine and psychiatry. And this year, we started with internal medicine. And we also have begun a process in which we're applying for and have just received status as a candidate, which means that we're entitled to a site visit towards developing a new medical degree program that will run along with our UCLA Share program. This new program will have 60 new students a year and will be entirely contained within the CDU community and enterprise. The history of CDU in terms of place. So if you look at the center of this map and you see this little hat here, that's where our university is. Back in 2000, These blue circles are areas where there are acute care hospitals in Los Angeles. And the green area is what we call South Los Angeles. As you can see, back in 2000, there was one acute care hospital in South Los Angeles. That was the Martin Luther King Hospital, which subsequently closed in 2007, as shown by this map. By 2019, although the new hospital had opened up at about a fifth the size of the old one, several of the other area hospitals have closed during that time period. And still no new hospitals, and a smaller area and a smaller set of resources for hospitalization, because the new hospital had opened up in South LA, as I mentioned to you before, was much smaller than the larger hospital that closed in 2007. Just a brief note on some of the context of in this region, this place of South Los Angeles where we sit. This is data from 2008 that demonstrates that in South Los Angeles, the death rate from treatable and preventable cancers was higher than any other part of Los Angeles County combined. The makeup of the community was roughly over 95% African-American and Latinx, and about 33% of the individuals uninsured, and almost 40% reported difficulty accessing care. Fast forward to 2017, the health statistics for these cancer death rates, many of them still persisted, some of them even got worse. The demographics largely remained unchanged. South Los Angeles is a Black and brown community. Encouragingly, though, the rates of uninsurance after the Affordable Care Act dropped from over 30% to almost 17%. So 17% still meaning a lot of people are uninsured, but a lot less than prior to the Affordable Care Act. The actual death rates from congestive heart failure, from diabetes, coronary heart disease, and stroke also reflect a higher rate compared to the other regions in LA County. And these chronic conditions in particular are chronic conditions which put people at higher risk for COVID-19. Unfortunately, the disparities that we've seen in these other conditions persist today and actually persist in the pandemic. This map once again shows you these regions. And if you look at the circle that's purple, that's the Westwood community. The circle that's red is the community surrounding our campus, particularly Watts, Compton, and Willowbrook, where we're located, had death rates from COVID-19 during this pandemic of 267, 283, and 315. That's the number of people who died for every 100,000 people in a region, compared to a place like Westwood in the upper left-hand corner there, which only had 55 deaths per 100,000. We know from the general statistics that people in poorer communities, Black and brown communities, have suffered adversely and disproportionately from this pandemic. The same is true for geographies. Place matters. One of the things that we've tried to do at Charles Drew at the very onset of this pandemic was to do our best to try to mitigate what we knew were going to be disparities driven by lower access to care, greater rates of poverty, and the disproportionate effect that COVID-19 and similar conditions would have on Black and brown communities. We began weekly meetings of CDU student, staff, and faculty to look at what we could do and what was going on around us in terms of community support for COVID-19. But we also had that meeting combined with our research faculty and staff to talk about what they were doing in the research world, to make sure that our research was informed by what was going on in the community, and that what's going on in the community could inform our research, and that we could have a collaborative effort to build the best of all of the resources that we had available. One of the early responses that we had was to provide testing on-site and on campus at CDU. Early on in the pandemic, there was very little to no testing available in the South Los Angeles community. In partnership with the county and the Board of Supervisors, the Department of Health Services, and the Fire Department of the County of Los Angeles, we opened up one of the first testing sites in the region. This is Dr. Sheila Young and our president, David Carlisle. Sheila Young, who was one of the instrumental persons and faculty members in the design of our system. Very early on, as someone who was and is a resident of South LA, knew that there were going to be different needs for our community. She mobilized our students to do volunteer canvassing and community outreach, encouraging people to come to our site to get tested, letting them know that it would be free, that insurance wouldn't be required. We were one of the first sites in the county to offer testing for people to walk up So you didn't have to have a drive-up appointment. You didn't have to go online. You could actually come and get tested that day. All of these things resulted in our testing site being one of the most high volume sites in the county, but also demonstrating that that brown, dark gray area, as opposed to the gold area, demonstrates the proportion of people who tested at our site that did on-site registration. People being able to walk up and on-site getting tested when they didn't need access to internet and didn't need to have a car. All of those things made a difference, and it showed in the reflection of who was tested at our site. By August, and we continued in partnership after that time at a site across the street with our Department of Health Services colleagues, we tested over 150,000 people. This map shows you the density plot where the large amounts of people who were being tested were coming from the area around our campus where this gold star is. And the wide blue circles show you the number of people per zip code, and the red wedge shows you the percent positive. We've consistently had a higher percentage of people testing positive. One of the things that we did was when people tested positive, CDU faculty and staff called those individuals. In addition to the call that they would get from the county, they called those individuals to find out if they had medical homes to help them connect to care, 30% of which did not. They asked them if they had a place to stay that night, 3% did not. And 2% requested mental health support services. Our residents and family medicine faculty and supervised students conducted these calls, and these calls helped us inform us about what was going on with the pandemic in our community. You can see the full report on our testing site at this website below. And one of the research projects that you'll hear about later that's being conducted by one of our colleagues, actually several of our colleagues, myself included, is about outbreak investigation and training for contact tracing evaluation. One of the things that we were very concerned about at TRUE was when people get calls from the public health department, in order to contain the spread of the disease, those who test positive need to not only just isolate, but they also need to let people know who they may have exposed in the past 2 weeks to get tested. And part of that requires them to give that information to the public health department under standard contact tracing protocols. The understanding that communities of color, immigrant communities, and communities with just a historic mistrust, of established institutions and government entities may not want to participate in this. We have subsequently developed a research project to really talk to people through surveys and interviews, both of people who tested positive from these communities, as well as those who made the calls, to better understand what are some of the things that helped them to actually participate in this, and when they didn't, what were some of the reasons why, and to ask everyone if there were suggestions about how we could do this differently, to identify new models of contact tracing to help us not only real-time reduce the spread of disease and similar diseases like COVID, but to help us prepare in the future for pandemics that might require similar public health interventions. In Los Angeles County, as in other areas, we've seen the disparities in vaccination. Unfortunately, because vaccination is something that actually has a benefit, those who get vaccinated die less and are hospitalized less. When there's a disparity in receiving that type of life-saving therapy, it's also a disparity that widens those differences amongst individuals who might get the vaccine and those who don't. The racial and ethnic differences in the uptake and in the use of the vaccine is one of these things that will likely widen our disparities. And we've started to see that as we've now entered this phase of the pandemic, where those who are vaccinated are living longer and hospitalized less, and those who are not are dying more and are hospitalized more. And as the disparity who gets vaccinated widens between races and ethnic groups in poor and under-resourced settings, the disparity in those negative outcomes will also widen. This is a challenge that we've tried to mitigate at CDU, and in partnership with the County of Los Angeles. One of the things that's relevant in terms of place, and place at CDU in particular, is our use of data and maps to help us drive not just our understanding of this, but our action and also our research. Now, these maps show you some early on statistics and early on differences in where a lot of the cases were on the left, the dark blue areas, and where a lot of the vaccines were, the dark blue, the light blue area on the right. And this light blue area corresponds to South Los Angeles in the maps that I've shown you guys earlier. Towards addressing some of these disparities, in partnership with the Los Angeles County Department of Public Health and their Vaccine Equity Advisory Committee Chair, Dr. Tracy Veal, we began to share webinars and information sessions with clergy members and representatives of faith-based organizations in these regions in an effort to increase awareness, education, and access. Moreover, there was a desire to actually look at the data, and one of the challenges were that a lot of the areas in which these low vaccine uptake rates were and these high Black and brown communities didn't have access to vaccine programs. Some of the larger hubs that were set up required people to drive to those communities. Some of those requirements also required things like appointments. But from the lessons that we learned from our testing site, CDU mobilized to support connections between faith-based organizations that could potentially house vaccine programs and our partners at the Department of Public Health to get and mobilize vaccine resources to those churches. We began a series of webinars and conversations, and in conjunction with the county, we developed programs to help identify churches that could serve as vaccine hubs. This extended into a larger program in which the the Los Angeles County Department of Public Health began to run parallel with our efforts with community-based organizations and faith-based efforts that they had identified to begin to do vaccine programs at churches. As part of that, we shared our protocols with churches, CDU faculty and staff who had relationships with faith-based organizations, helped to get them prepared and send information to serve as vaccine sites. When we mapped out those resources and the faith-based organizations that we had relationships with, that we provided to the county, you can see here in South LA, a large number of the churches here were in South LA and in around South LA. And it corresponded to a lot of the deficit areas where the vaccines were not being given. Subsequently, that county program went on to provide over 30,000 doses of the vaccine as of June, and I believe probably close to 50,000 to date, with over 300 churches involved overall. Lessons learned from this, and this just shows you that a large number of those churches, I believe almost 50% were in the South LA region that participated in this county program. Lessons learned from that, we began to understand, and CDU actually has had a long history of doing research with faith-based organizations to better understand and design interventions to reduce disparities. Several of these programs included new research that you'll hear about. Dr. Mohsen Bazargan and Sharon Cobb have NIH funding to coordinate and recruit churches from some of these faith-based organization programs to actually train health advocates to not only encourage their congregations, but to go out into the broader community to get vaccines. The mobile health outreach team has been actually working with our partners at Kedron Health to provide vaccines at faith-based organizations in other regions. And I served as co-chair with Dr. Tracy Veal on the Vaccine Equity Advisory Committee. Several of those research projects are noted here. You'll hear about the multi-level faith-based program by Dr. Cobb later in the week. And active research is now going on to extend that program into public housing communities in these geographies where people are living in county-sponsored and county-supported housing communities, to engage those community members in being trained on the best evidence on what is needed to reduce the spread of COVID-19. And then we're also conducting research with Tessie Cleveland and other organizations in the South LA region to help healthcare providers, mental health providers, and those who are providing social services who are interacting with communities for other reasons to better address hesitancy issues in vaccine uptake. Other examples of how we've looked at this aspect of place and the dearth of vaccines or the higher risk of death and disease from COVID-19 includes looking at where the vaccine programs were. This is a map from in the spring of 2021 that demonstrates where the county-sponsored vaccine programs were, and actually all of the vaccine programs, that were supported, both fixed locations and community health centers and pharmacies. But if we took a deeper dive when we looked at that, and we look at an area just south of our campus in this red box, the Compton area in particular, and parts of South LA, here, you can notice some gaps. And these spaces might not seem like very big spaces, but if you don't have a car and you have to walk, that can be a barrier and an impediment to getting vaccinated. We begin to then look at, well, what could we do to better understand, better share data with these communities about vaccine and vaccine uptake, and what could we do to share with our community partners and our partners at the county to better understand how we can get vaccines in some of these areas that had gaps. One example was that when we looked at that map, we then did a deeper dive and began to look at the vaccine rates in Compton and created these maps and began to collect data to see where we were doing well and where we had needs. And at this point in September, we had actually done pretty good with the seniors, but the younger groups were the areas where there were deficits. We had been running a series of vaccine programs in parks and noted that the vaccine programs in the parks were largely folks who were under 65, largely folks who were also uninsured, and people who might have just felt more comfortable going to a park. They may not have had primary care sources, or they may have just had the capacity to go to the park because we stayed there till sometimes 6 and 8 at night. And so those folks who were working might have a better opportunity to go there. We took that data and that information in those maps, and we met with leaders from the Compton area, including the mayor's office, their city council, physicians, and clergy in that region. And we began to share data to say, what can we do to better help support vaccine programs? And we began to do vaccine programs and actually have our mobile unit go to those regions where there were gaps on the map. We partnered with our colleagues at an organization called, a company called Cogitativo. They provided us with information by region and actually by zip code that you can see here that showed us how many people in those communities actually had risk of hospitalization or death. And you can see that almost 22 to 20% of people in a lot of these zip codes were at risk for hospitalization and death if they had COVID. Sharing this information with the community and with the leaders, we feel helped better inform them and hopefully would help to encourage those groups and community-based organizations in these regions to partner with us to help promote the vaccine uptake. We then would share these maps and actually hopefully modify by putting vaccine programs in regions where they weren't, and also sharing the data where there currently were vaccines with these community members. We begin to look at other regions, and as you can see, the Palmdale Lancaster area up here in the northern part of LA County, in addition to Compton, which is down here in the yellow, were areas in which we began to rank the lowest vaccine uptake regions in the county and began a process of reaching out to the faith-based leaders, the politicians there, and then having our mobile teams set up programs to actually provide vaccines in this region. This is a QR code of a COVID-19 newsletter that we put together, showing where we're at with the mobile vaccine unit. What are the hardest hit communities, both in terms of COVID negative outcomes and lack of uptake of the vaccine. We've had a host of partners you can see here that have been working with us, supported by our Kedron clinical affiliate colleagues and Dr. Jerry Abraham and Reverend Donisha Beavers. We've joined the mobile team of Dr. Almon Rogers and Professor Cynthia Davis to come together to have a really strong supported approach for this outreach. This has bled over into research, and this research has included efforts by Dr. Robinson, who you'll hear from later in the week about his ongoing research, and a presentation by Daniel Ryan of the GIS lab, which is part of our health policy pillar at CDU, on how the GIS lab can support analytics to support informed decision-making for action, but also for research. And you'll be seeing some of these research findings from Dr. Robinson and Dr. Rogers later in the week. In addition to this, we partner externally with our colleagues from the RAND Corporation, our colleagues from Cogitivo, to actually develop simulation models and regression analyses to help us inform future decisions about how we can allocate resources and what modifiable factors might be related to either poor uptake of vaccine, as well as negative health outcomes associated with lack of access to vaccine, and how we can make sure that we either address them immediately and inform our colleagues in the future. So with that being said, I welcome you to the Place at CDU series. I thank you guys for spending time with us. Our Urban Health Institute and our Urban Health Institute's Health Policy Pillar have, really tried to make extensive pains to understand the health disparities that are faced by underserved and under-resourced communities, but to do this in context with our CDU mission and our CDU advantage. So I thank you, and I hope you enjoy the rest of the series.